Okay. So this is a forest plot in front of you, and they are telling that this is a comparison, and you can see the comparison with or for oral brufen versus intravenous or oral indomethacin. Okay, so two groups are there. One is with oral brufen and the other one with the indomethacin. Okay, and different studies are in front of you, and they are saying which study is more significant. Okay, so significant, if they are asking about, so I'm just little bit zooming the studies. So for significance, as you asking, the side of the diamond will tell you that the significant study would be in related to the oral brufen, because oral brufen is towards, first they mention about the oral brufen. Okay, so this side is related to the oral brufen, and this side, the other side, this side is related to the oral or intravenous indomethacin. Okay, so diamond is towards the if I talk about, let us assume this is your right and this is your left side. So diamond is towards your right side. So of course the studies are more towards, the more effective studies are more towards the oral brufen. This is the first conclusion. Okay, now the second question they ask about, that among different studies, which one is more significant? So those studies which are crossing the midline, they are not significant. They are not significant. Remember it. So if you closely look up their confidence interval as well, their confidence interval also, so before interpreting the confidence interval, you can see that which table they are using it. Okay, this is a very blurred picture, but what I can see over here is that which factor they are using, odds ratio, or they are using relative risk. This is very important, because if you know the scale, then you know that this center line is indicating either the center point is 0 or 1. Okay, if the unit is in the if the unit is in the relative risk or in the odds ratio, then this center point would be 1. If this value is in the mean value, mean difference, something standard deviations, then this center point would be 0. Okay, so that is why it is very important which they are using. Okay, over there I think they are using percentages, as far as I can see over here. Events total, they are giving the values probably in the percentages. Okay, so the values in the percentage, and if you look at the confidence interval range, okay, if you look at it, almost every study is crossing the midline. If they are crossing the midline, definitely they would not be that significant. Okay, and if you look at the interval range, confidence interval, another give you the answer that if the value is contained one in it, that means that study is not significant. So start from the first value, 0.29 to 1.23 contain 1.00. Again, next question, 0.01 to 2.50 again contain 1.00. This value also contain 1.00. Now talk about this one, 0.33 to 1.04 to 2 point. This value does not contain 1 in it. This is the first study. The second study is below. Again 1.06 I think to 1.47. These two studies does not contain 1.00 in it. What is the name of these studies? So if I go back, Names clear. 2002 ki one study is related to, I think, 2002, and the another is 2014. 2014, okay? So probably if talk about, even though they cross this center line, so I think either the problem is in the graph, okay? So any study, if they are crossing the midline, the first thing through the midline, you can say that. So if they're crossing the midline, that means that study will contain 1 in it in the confidence interval range. So I'm not sure about this. If in the this confidence interval range, if you do not contain 1.00, then you cannot cross the midline, okay? So from this point of view, right now, by looking at the confidence, okay, risk ratio. So your unit is in the risk ratios, okay? Risk ratio, this is, I think, risk ratio. So risk ratio, the center line is 1, okay? So over here, the oral brufen would be more significant. And if you talk about with this, I just conclude only talk about 2014 Yadva study, the E study. Okay. By looking at the confidence interval ranges. Okay. But this graph is not basically helping me. This graph should not cross this midline. Okay, Dr. Saad, is that clear to you? What does the square in center? The square in the center is telling you about the population size, the number of population, the, you are studying, of course, in each study, your population size. So this small boxes is telling you about the population size, total number of population in which you are doing study. Okay. Is that clear about the forest plot? Okay. Now just discussed our 2024. Is the length of the horizontal line significant? The length of the horizontal line will not tell you that much. If you're talking about, it tells you about the range, like just this confidence interval range. So if that range would be prolonged, very long, like in this study, you can see that from 0.01 to 2.5. So the range is very long. So that is why this line is very long. Okay. So it tells you about actually the range. How do we conclude the answer? The conclusion is based upon, first of all, you can see the diamond shape, where the diamond shape lasts. This is the summary of your study, where this diamond shape is lying. If is it towards this. If it is towards right side, that means it is more talking about significance about the part 1, okay? Right side of your study part. Second thing is that you can look upon the p values as well. So in the last, because this is the quite blurred. So if you look at the last part of your this last study part over here, you can see over here the p values would be mentioning over here. So that p-value, if it should be less than 0.05, that means the study is statistically significant. Okay, that's all. And by looking at the other studies, you can see that which studies in favor. Those who are not crossing the midline, they are not, they are significant. Those who are crossing the midline, that means they are not significant. Those who are crossing the midline, they are not significant. Statistical p-values would be written somewhere over here, because I cannot oversee over here. The p-values are over here. So overall, if you get any conclusion, that would be, final summary by the p-value. Yes, this forest plot is not correct, because the confidence interval range does not contain 1.008, despite that is crossing the midline. So that is why I am not convinced with this forest plot. Okay. Okay. So you can that's all. So if you don't understand from this point of view which study is important, then go back and check the confidence interval range. Any range which does not contain 1 in it, that study is significant. Okay, that's all. Okay, thank you. Otherwise, forest plot definitely will correspond with their results. Yes. Okay, so let's share the 2024 paper with you people. Okay. Okay. Just a second. Let's start quickly with this paper first, 2024 TAS paper, okay? Isolated lactation is caused by which drug, which is the side effect? This is the side effect of the cyclizine, okay? That cause isolated lactation. Neuromuscular disease affecting the peripheral nerve lesion, that would be peripheral nerves, is by GBS, and hereditary Charcot-Marie-Tooth disease. Interstitial lung disease flow meter. What shows the interstitial lung disease? That means restrictive diseases. So restrictive disease chart would be this. Everything would be, would be decreased. Okay. When you talk about this coving is very characteristic for obstructive disease. While in case of restrictive disease, there would be no coving, no concavity on the expiratory part. Okay. So if you just see the concavity, the coving in the expiratory limb, that is suggestive of the obstructive pattern. Okay. Which of the following factors can increase the delivery of oxygen to the muscles? Which of the following factor will increase the delivery of oxygen to the muscle? So this is related to the, of course, oxygen dissociation curve. Oxygen dissociation curve will shift to the right. Right means it will give. Right people are the one who are donors. Okay. So in which situation, the if it shift to the right, it will give oxygen. It will release oxygen from the hemoglobin. So in which situation? So it is the fever is the situation which is associated with the right-sided shift of the hemoglobin dissociation curve. Okay. Next, what is the baclofen mechanism of action? Baclofen, what we discussed last time, the baclofen mechanism of action. The baclofen, which I can recall, is that it blocks the release of acetylcholine. Baclofen, it's not the inhibitory on the GABA. Promote. Baclofen, okay, I think yes, baclofen is on GABA. Yes, let me again check it. I forgot. Baclofen. Baclofen, I think yes. Baclofen mechanism of action. Yes, baclofen is thought to reduce the release of excitatory neurotransmitters in the presynaptic neuron and stimulate the inhibitory neuronal signals in the postsynaptic neurons, result in spasticity relief. It has also affinity against voltage gate calcium channels as well. So yes, baclofen is a GABA agonist. It's a GABA agonist. Okay, it's a GABA agonist used as a skeletal muscle relaxant. So this is the function of the baclofen. So inhibitory, yes, it promotes. No voice. No voice to everyone. Voice okay? Okay, okay, voice okay. So what is basically working on the GABA receptors promotes the inhibitory action on the GABA. Yes, so it is basically promotes mean it is agonist. Okay, inhibitory action on the postsynaptic neurons at the muscle plate. Okay, so yes, this is right. What is the plasma light component? So they have mentioned already the answer. You should remember what plasmolite contain. Plasmolite contain potassium other than the sodium, which the normal saline does not contain. Okay, sodium is high. Okay, 140. In the normal saline, your sodium is around 156 probably. So you have to check it. Plasma light contains slightly low sodium. I think so, which I can recall, or I can check it as well. 0.9 normal saline constituents. So if I just open the 0.9 normal saline constitute, yes, sodium is 150. Okay. Sodium is 150 and chloride is also 150. So the normal saline contains sodium and chloride on the higher side. Okay. Sodium is 150 in the 0.9 normal saline. Chloride is also 150. So the plasma light give you the potassium, slightly low sodium, and low chloride. Okay. Teenager boy with urethral discharge. So we'll perform the NAT test. Okay. During night shift, best option is take a nap for 45 minutes. Sorry. Take a nap for 45 minutes. Which case hepatitis B show infectivity? Infectivity is basically shown by the HBe antigen positive. So the answer would be A, E antigen positive. What is the mechanism of action of the allopurinol? Allopurinol is a xanthine oxidase inhibitor. Okay. Cause of hypokalemia in the DK patient. So this child presented with diabetic ketoacidosis. It's not on the treatment. So when the child in the DK, why is hypokalemic? Because of the osmotic diuresis. Very good. Which of the following medication commonly prescribed to children that can interfere with melatonin function found to cause sleep disturbances? That is Montelukast. Yes, genetic confirmatory test 22q1 deletion is checked by the fish. Okay, specific deletion is checked by the fish. Now, when you look at this ABG, that shows acidosis clearly 7.1. If you look at the PCO2, that is raised, that means respiratory. And if you look at the bicarb value, the bicarb value should be high. What you expected in the respiratory acidosis, the metabolic bicarb should be on slightly on the higher side, alkalosis, and a compensation. Okay. In 12, isn't in the levetiracetam. Sleep disturbances is mostly caused by Montelukast. Let me check it that Montelukast causes melatonin interference function in it or not. Let me check. Levetiracetam you are talking about. I think so. Sleep disturbances are more common with the Montelukast. Montelukast interaction with melatonin. Montelukast interaction with melatonin. Sleep behavior mood infrequently reported, and I think not with the levetiracetam. with this Montelukast, levetiracetam. Levetiracetam does not have sleep issues, I think. Levetiracetam. Side effects. Levetiracetam changes in the mood, your behavior, problem with coordination, unusual tiredness or weakness. Not with the sleeping problems. Okay, so I think yes, Dr. Saad, that would be more with the this Montelukast. Okay, the next question, number 14. 14 is respiratory and metabolic acidosis, because bicarb should be higher, what we expected. They are just on the lower range of the normal. That is why it is a mixed picture. Okay, hemorrhagic disease, prolong both PT and APTT. 2-month-old child, exclusive breast mother feed, deficiency would be vitamin D. They did not mention about over here. 2-month-old on exclusive mother feed, which vitamin is deficient? A, B, C, K, E. I think vitamin D, and if vitamin D is not, then vitamin K, because vitamin K is, that's why we are giving extra. So mother feed does not contain enough amount of vitamin K. Okay. Action of the proton pump inhibitor is on binds to hydrogen potassium ATPase and blocks the HCl secretion. Part of the eye that originate from the ectoderm. That originate from your ectoderm. It's the iris, it's a corneal epithelium, I think, which are arise from the ectoderm. Corneum epithelium. It's a corneal epithelium that arises from the ectoderm. What is the levetiracetam mechanism? So they have already mentioned. They work on the synaptic vesicles, protein specific protein SV2A. Yes. Next question. Drug administered IV. Which one of two is about the first order kinetics? This is related to the drug removal. Okay. We have two types of first order and zero order kinetics. Okay, I think I have mentioned it in my lecture. Zero order kinetics. Sorry, what you were asking? Question number 19 is answer A. Okay, levetiracetam specifically work on the presynaptic vesicle protein SV2A. Okay, we have two types, zero order and we have first order pharmacokinetics. Okay. First order means that the rate of elimination is depends upon your plasma concentration. This is first order. For example, what is the difference between it? You have consumed 100 mg brufen, okay? In both cases, you have consumed same amount, 100 mg brufen, okay? So what happened in the first order kinetics, that 50% of it will going to be eliminated. So what happened after, for example, if the half-life of that brufen is, let's assume 2 hours. So after 2 hours, 50 mg will going to be removed from your body. Then after 2 hours, 25 mg will going to be removed from your body. Then after 25 mg, after 2 hours, so every 2 hours, you are removing half of the drug. 12.5 mg will going to be removed. Okay. So what happened, that the removal is depend upon your concentration. If you take in 100 mg, initially 50 mg was taken out. Then once 50 mg is left, then the half of the 50 was 25 mg. So in the next cycle, you just remove 25 mg. So why you remove less amount? It depends upon the concentration you are taking. What happened in the zero order kinetics? If you start with the 100 mg, let's assume that after 2 hours, 90 mg drug would be left. Then after 2 hours, 80 mg drug would be left. Then after 2 hours, 70. Same amount will be removed after every 24 hours, that is 10 mg. That does not depend upon your plasma concentration. So if it is independent of plasma concentration, that is called zero order. If it is depends upon the plasma concentration, if you are taking high amount, then definitely half of it will going to be released, half of it going to be removed. So this type of kinetics is called first order kinetics. Okay. So I think it is clear what is the difference between the zero order and the first order kinetics. Okay. Is that clear? Next, 12-year RTA to the emergency soon after arrival. So they are asking about in the extradural hematoma, blood vessel is the middle meningeal artery. Mechanism of hypokalemia with the salbutamol. So salbutamol causes the shifting of the potassium, okay, inside the cell. Okay, so what does it basically do? That it causes shifting of the potassium. I think the shifting of the potassium would be in exchange with probably with the, I think with sodium, intracellular shifting of the potassium in exchange with sodium. Let me check it. I think with hydrogen. Let me check it. With sodium, everyone saying with sodium. Let me check it. Hypokalemia. Just let me check it quickly. Hypokalemia. Hypokalemia with salbutamol. Mechanism. Salbutamol induce hyperglycemia and hypoglycemia, and it acts by sodium potassium ATPase respective. Okay. Both of these effects are due to the stimulation of the beta 2 receptors, which activate the sodium potassium ATPase, thereby driving potassium into the cell. Okay, so okay, sodium potassium ATPase pump through sodium. Okay, you people are right. Okay, next. So this is intracellular within the cell shifting with the sodium through sodium potassium ATPase pump. Okay. Now the next question, 23. After NVD, transition of extrauterine circulation. So we have discussed catecholamine play a role in reducing lung volume. Now this is a 3-year-old girl presented with the stridor. So stridor, if they talk about what type of obstruction the stridor is basically caused by fixed extrathoracic obstruction leads to the stridor. And what is the stator? Stator is, it is intermittent. It is not fixed, okay? It is dynamic extra thoracic obstruction that can change with the position, okay? Straighter and strider. Next question, you discharge CP patient who receive Botox for the spasticity. How does Botox reduces? So we discussed that it blocks acetylcholine at peripheral nerve endings, okay? I think, yes, that would be the answer. Botox. We discussed, I think, Botox last time. Botox. Botox by binding presynaptically to high affinity recognition site on the cholinergic nerve terminal, decreasing the release of acetylcholine. So peripherally it is working, okay, presynaptically on the cholinergic nerve terminals, okay. Okay, next question. 14-year-old girl. Now they are talking about the lung functions. So what the lung function is predicting, that FEV1 is normal. 84% predicted means normal, okay? And if you look at the FVC, that is also normal. So both are normal. But when you look at the exhaled nitric oxide, it is very high. So we all know that if it is very high, that means this is related to the poor control asthma. because in cystic fibrosis, in PCD, the axial nitric oxide value would be very low. Okay. Now, what have then they given you? This is the a forest plot meta-analysis. We don't have a forest plot, so we cannot tell anything about it without, because meta-analysis can only be given answer by looking at your forest plot. Okay. Now, baby delivered by ventouse, prolonged labor with swelling in the head that crossed the line, pale and shocked. So, pale and shocked means which layer? The layer would be within the aponeurosis, cephal. Yes, that would, if it no would have been normal. Yes, if axial nitric oxide would be normal, would have been normal, this would indicate proper control. Yes, that would indicate normal PFTs. If you're in axial nitric oxide would be normal, that indicates that your PFTs is everything is okay because your values are okay. So because asthma is a reversible disease, so sometime your PFTs would be entirely normal. Then for the diagnosis of asthma, you have to give, you know, challenge. You have to go for exercise for some time. You have to give salbutamol to look at the response for that. So challenge or these tests, further these tests are performed for the diagnosis of asthma, because asthma is a reversible condition and you may find normal PFTs. So if your NO, axial NO would be normal, in that case, that indicates this is a normal PFTs. Okay. So I think this is the subglial aponeurosis, and we have already discussed the subglial is this one. Where this is the sub. I cannot look through this picture. This is the subglial. Yes, this bleed subglial. Okay. So this, they did not mention the layer number, but you should have idea that subglial is basically it is your in the, yes, layer B. That would be layer B. Okay, so over here they did not mention about the layers, so we cannot exactly say which layer. Okay, but the thing which we should know is that we should actually know that it should be below the aponeurosis. This green line is your aponeurosis and it is below the aponeurosis. And this blue line is your periosteum. This blue is periosteum. So you should know exactly which layer is this. And this layer is your skin. Okay. Now the next question about the diaphragmatic hernia. It's a pleuroperitoneal canal defect, pleuroperitoneal. Now look at the question that right reflex done on the right eye contracted but left eye not contracted. Turns to left side, left eye not change, but the and right eye would be contracted. So what do you think? What is the problem over here? Problem over here is that left eye is not contracted. Okay, so the if right eye, just make the eyes. It's a simple question, but I'm explaining it quickly. You just put the light over here. The right eye contracted means 2 and 3, both nerves are entirely normal. You will agree with me quickly. But left eye not contracted. That means indirect reflex in the left eye would be mediated by cranial nerve 3. So 3 is damaged of the left side. Then what they do next step, now they put a light on the left side. So the left eye again not contracted. Okay. So we are unsure whether 2 is right or not, because contraction is mediated by both 2 and 3 if you directly put the light on it. Okay. So when I directly put the light on the left eye did not give any response. So I was unsure about 2 and 3. I say maybe both are involved. Then I look at the right side. The right side is contracted. So why the right side eye contracted? It means that the optic nerve is okay. That is why that is giving signals to the right eye. So that both test confirms that only the third nerve of the left side is involved. Okay, so left oculomotor nerve injury. I think that is clear. If not clear, you can ask quickly. Next question, 18-month-old girl came to ER with afebrile generalized tonic-clonic seizures. Please explain again. Okay, listen it again very carefully, Roxanne. This is your right eye. This is your left eye. Okay. When they just shine the right eye, okay, the right eye contracted. The right eye contracted means right eye 2 and 3 is intact. Okay. Direct reflex was done. So direct reflex, right eye is contracted. But when you look at the indirect reflex, by just putting the light on the right, and when you look the left eye did not give any response. The left eye response was mediated in the indirect reflex by third nerve. So there is no contraction. I suspect that third nerve is damaged. Okay. Now what I did is the next time what I did, I directly shine the light on the left side. I just perform a direct light reflex. Okay. What I saw in the direct light reflex on the left eye, no response. If there is no response with the direct light eye, I suspect probably second and third would be involved. Now, how would I confirm that the second optic nerve is okay? I just shine the light on the left, but I will look on the right side. If the right side giving me response, if right eye contracted, how it contracted, I was shining the light on the left. I was shining on the left. Why the right eye is giving me response? Because the left second optic nerve is intact. The left eye is sensing the light, giving response to Edinger-Vaspar nucleus of the both sides. So the third nerve of the right side is okay. That is why it is contracted. Third nerve of the left is not okay. That is why there is no response on the left eye, either by giving direct reflex or indirect reflex. That confirms that third nerve injury, isolated third nerve injury is there. If both will going to be involved, there would be no response in the right eye. Indirect reflex would be nothing. You got it now?
Madam, in this scenario, if we shine a light in the left eye, so
Hmm.
left pupil will contract or not? Will contract, right?
If you directly shine the light on the left eye will
Yes.
only going to be contracted if the light sense is taken by the cranial nerve 2. 2 should be okay. And the efferent pathway bring by third nerve, okay? That mediated contraction. If any one of them will going to be involved, the response would be 0. Any one of will going to be involved. Either 2, either 3. Then how you would going to confirm it that which nerve is involved? So what you see over here, you are shining the light on the left, but you are looking at the right side. And if you see right side is contracted, so what conclusion you will bring if you look that the right eye is contracted? Why it is contracted? How the right eye is getting signal? How is getting input? It getting input from the left optic nerve. You got it? Left-sided optic nerve was okay. The input was okay. That goes to the Edinger-Vaspar and to the oculomotor nerve of the both sides. But because left is involved, oculomotor, left side of the oculomotor is involved. That is why left is not giving any response. Right is giving response. That means left side of the optic nerve is okay. Now you got it? Okay, that's great. Next question. 18-month-old girl came to ER with afebrile generalized tonic-clonic, and if you look at the calcium is low. So what is the problem over here? And over here, the calcium is low. Phosphorus, if you look at it, it is on the higher side. Calcium is low. Phosphorus is on the higher side, 2.1. 25 hydroxy vitamin D is also normal. Alkaline phosphatase, not too much increase. PTH level is very low. So what is the cause over here? So we know that what is the cause over here is that if you don't have PTH, okay, you would not have a 125 vitamin D, okay? And 125 vitamin D will not, if it is not there, then it will be defect in the osteolytic osteolysis. Answer would be A. Because increased calcium absorption from the gut will be mediated by 125 hydroxy vitamin D. So in the absence of it, there would be no absorption. A would be the answer. Preschool child came for hearing. History of the came for hearing test with the history of neonatal infection. What is the cause of sensory neural? So this is mediated by CMV. Newborn with bilateral absent reflex born at term. Most likely, what could be the answer? So this is a newborn bilateral absent red reflex born at term. What could be the likely cause for that? So it could be rubella, most likely eye involvement. Girl with erythematous itchy skin and her recent nickel ear piercing. This is type 4 hypersensitivity. Preterm with interventricular and periventricular is fluctuation of cerebral blood flow. Excitatory neurotransmitter is your glutamate. Baby born 37 weeker, weight 2.3 kg, at day 9 presented with jaundice, weight was 1.95 kg. Blood glucose is also low, liver is 1 cm, investigation was done. Creatinine high, urea is 9.5, blood glucose is low, cortisol low, sodium low, potassium high. So probably you are on insulin undetectable. Urinary sodium is high. You are losing urinary sodium. This is most likely the CAH. Cause of Enterococcus bacterial resistance to cephalosporins. So cephalosporins, why the cause for that? Cephalosporins also work by beta lactamase. So it's a production of the beta lactamase that leads to resistance to the cephalosporin. Cause of Enterococcus bacterial resistant to cephalosporin. So penicillin and cephalosporin both are resistant because of the production of the beta lactamase. Adverse effect of electronic bibenzyl aldehyde. Patient is brought to the emergency department, road traffic accident. Family inquires about the possibility of the organ donation, and you see over here, what is the criteria for the brainstem death? So we have discussed absent gag reflex is the answer. Child presented for follow-up, increasing head circumference. Ultrasound revealed mild dilatation of the lateral but severe dilatation of fourth ventricle. That means obstruction is below the fourth ventricle. And what is below the fourth ventricle is your foramen lusca and foramen magneti. Okay. Father with sickle cell, mother, no known her status. Okay. Over here, father with sickle cell disease, but mother ka you don't know the status, but maternal grandfather died from sickle cell crisis. So maternal grandfather died from sickle, that means maternal father was sickle cell diseased. That means mother would be a carrier, definite carrier. Okay. So father is the disease and mother would be definitely carrier. Okay. Chance of her daughter to be carrier. So what is the chance of her daughter to be carrier? So if you just like, this is the disease, this is the carrier. So 2 is a carrier. Okay. Third is again disease, and 4. So 50% chance of being carrier over here. Okay. Now in a study of a new spacer we discussed that the children can reject dobutamine. Mechanism of action is dobutamine works on both, I think, beta 1 and beta 2 agonist. Researcher, yes, researcher is only beta 2. Let me confirm then. Dobutamine, no problem. We can forget dobutamine. Dobutamine mechanism of action directly stimulates the beta 1 receptors of the heart to increase the myocardial contractility, and dobutamine causes vasodilator as well. So both, Dr. Saad, it works on beta 1 on the heart and beta 2 on the blood vessels. Okay, that is why the dobutamine cause a vasodilation. Okay, so it's agonist. Now, researcher comparing the difference in three groups. So we're talking about the three groups where the data distribution is also skewed. It is not normally distributed. Okay, and which statistical test is most appropriate to used in that case. So skewed data, and you are checking three group. So what is the test for three groups? I think Krukel-Wallis test probably, which I can recall. Okay, yes, it's a Krukel-Wallis test. Okay. Next, corneal reflex is mediated by 5, and blinking is mediated by 7. So 5 is the one which takes the sensory input from the ophthalmic division of the trigeminal nerve, and when you close your eyes in response to that, that is mediated by the 7th nerve. Okay, baby 6 months with nephrocalcinosis, and if you look at it, it is hypercaloremic, normal anion gap metabolic acidosis. So normal anion gap metabolic acidosis means RTA. Okay, metabolic acidosis, normal anion gap, RTA or diarrhea probably. So you are dealing with the nephrocalcinosis. Nephrocalcinosis is associated with the RTA. So always remember metabolic acidosis, normal anion gap, two important condition, RTA and DK. RTA is associated with the nephrocalcinosis. And when we talk about the different type of RTA, so which RTA is associated with the nephrocalcinosis? Which RTA is associated with the nephrocalcinosis? Yes, type 2 or the type 1. It is because type 1. Okay, so decreased hydrogen secretion in the renal tubule, not the type 2. No. It's not type 2. I think it's type 1. Because in the type 2, you can acidify the urine. Okay, you can acidify the urine. So acidification always inhibits stone formation. Your alkaline medium will promotes stone formation. Okay, always remember acidify will can cause, you can see the acid can dissolve each and everything. Okay, so in the type 2, because acid secretion is intact in the type 2, that is why that is against the stone formation. So yes, type 1 is associated with nephrocalcinosis and stone formation. Procoagulation factor synthesized by endothelial is von Willebrand factor. Which of the following is a polysaccharide vaccine? So polysaccharide is our this is a Streptococcus pneumonia. Okay. Now, HIP is a conjugate vaccine combined with other, and diphtheria is a toxin. Okay. Listeria we don't have any vaccine for listeria. Okay. Now, the baby antenatal ultrasound revealed dilated pelvic axial system with a normal bladder. So, dilated pelvic axial system with normal bladder. And which of the following is the best diagnostic to determine if there is a urinary obstruction? So to look at the urinary obstruction, the MAC3 with the furosemide would be the best. That will tell you about the function of the kidney with the obstruction, whether it is how much obstruction is there, how much problem is there. Okay. A patient with anorexia nervosa, BMI less than 30, which of the following factor is most likely contribute to the long-term effect of the future bone density is mediated by estrogen levels. Okay, low estrogen levels. Drug that can blocks the inosine monophosphate. Inosine monophosphate. Yes. I think this is by mycophenolate motifil. Okay. Okay. Thank you for confirming. So this is the mechanism. Now, the patient is diagnosed with the syringomelia at T6 level. Syringomelia means that cavity in the T6 level. What sensory loss is most likely associated with this condition? So, syringomelia is basically involving the central part of your spinal cord. So, what are the sensory tracts which are traveling in in the center? So, in the center, your pain and temperature. Okay, pain ones. Okay, laterally, your vibration, posterior columns are there. Okay, so what sensory is most likely to be associated with it? So it would be loss of pain and temperature, because they specifically ask about the sensory. So we talk about only the sensory, the pain, loss of pain and temperature below T6. Okay, so everything below would going to be involved. Okay, not the above, not the above. Okay, so in the center, pain and temperature, and laterally you have vibration and your proprioception on your light touch. So in the syringomelia, central part of your cord is involved. Initially start in the center. That is why first your center will going to be involved. Okay. And it will be below 20, below T6. Okay. The answer would be A over here. Site of synthesis of ADH synthesis in the hypothalamus, and then it goes to the posterior pituitary for storage purpose. Ethosexamide mechanism of action. Ethosexamide calcium channel blocker. Okay, ethosexamide is a calcium channel blocker. Patient came with toxic shock syndrome and received streptomycin and clindamycin. So clindamycin inhibition of the bacterial toxin. 6 year with meningitis, gram positive cocci. So what could be the organism? If it is gram positive cocci, this is streptococcus pneumonia. Now the next is the pedigree is there. What you can see in the pedigree, that the parents are not involved over here. Parents are not involved and the child got the disease. So this is most likely recessive diseases only involving the male, most likely X-linked recessive. Okay. In that way, you can make the things simple. Okay. Only gender male is involved and parents are okay, and still the child is having disease. This is recessive. Most common HUS, E. coli. Factor that promote immediate closure of the ductus arteriosus. Closure is mediated by Closure of the PDA is mediated by hypoxia, decrease prostaglandins. Yes, decrease prostaglandin, because these prostaglandin, why they will be decreased? Because you clamp the cord and you lose the connection from the placenta, and placenta is giving you prostaglandins, okay, to keep the duct open. Okay, so that is why immediate closure would be the decreased prostaglandin E2. Okay. Loss of these why not option 2? Peripheral vascular resistance is increased. Okay. When the baby is born, your peripheral or your systemic vascular resistance is increased. So it does not have a role directly on the ductus arteriosus. Why your duct is open? Your duct is open because of the low oxygen, the first factor. The second factor, prostaglandin are produced by the placenta. So when you want to keep the duct open, what you're going to do? You again give the prostaglandins. Okay. So because lose of connection from the placenta, your prostaglandins will not be there. That will work in immediate closure. Another thing is increase in the oxygen also play a role in the closure of the ductus arteriosus. Okay. Pulmonary vascular resistance decrease. Okay, the slowly over the time. Okay, over the time. It takes time, okay? Next, mechanism of action of insulin. So insulin causes fat deposition, is causes stimulation of the everything it will form, it will not break, okay? So stimulate glycogenesis, stimulate fat, the B answer. No, dear, it will not break the glycogen. Why it will break the glycogen? It will inhibit glycogen lysis. You already have glucose. There is no need to break the glycogen. Okay, that is making sense. Inhibit gluconeogenesis. You don't need to make glucose. You already have too much glucose in your blood. Okay, so the answer would be B over here. 2-year-old girl with proptosis and lid lack. What could be the cause over here? So this is most likely Graves' disease. No shoes. This is the Graves' disease. So antibody stimulating TSH receptor. What is the primary mechanism of action of IGF-1? Insulin-like growth factor directly work on the chondrocyte proliferation. Okay. So this is IGF-1 directly work on the chondrocytes. Now this is a 3-year. Dr. Sad, you can directly ask it, no problem. You can directly option 4 marker Vayata. Which question you talk about? You can directly ask it on the if you okay. Well, at that time it was not opening. I'll check it and tell you what you are asking. Okay, next question. Dravet syndrome. Dravet is associated with sodium channelopathy. Okay. Next question. This is the boy, 3-year-old boy presented with clinic with abdominal distension, weight loss, irritability over the past few weeks. Irregular mass is palpable in the abdomen and raised BP. So raised BP, weight loss, irritability, what you will going to find out in the urine, okay? So we all know that in the urine, what we basically find out in the urine, it's tyrosine, epinephrine, dopamine, or phenylalanine. This is, they are talking about the neuroblastoma. Neuroblastoma, the catecholamine levels are high in the urine. Okay. So if we talk about, they are basically asking the, what I told you at that time, catecholamines in the urine in the neuroblastoma, which catechol. So we are basically checking basically metanephrines we are checking na, in urine with neuroblastoma. Metanephrines or vinyl mandelic acids. They are coming from the adrenal gland tumors or other type of the tumors. Metabolites, just a second. Epinephrine and norepinephrine. See, mandelic malic acid is a chemical intermediate in the synthesis of and end stage metabolites of the catecholamine, epinephrine, and norepinephrine. So the answer epinephrine and mandelic acid is one of the breakdown products of epinephrine and norepinephrine. Epinephrine and norepinephrine belongs to the similar hormone called catecholamines. epinephrine break down into metanephrine and mandelic malic acid, and norepinephrine break into normetanephrine and vinyl mandelic acid. So this is actually, if indirectly they are asking about how they are coming, the metanephrines and vinyl mandelic acid, how they are coming. They are coming from epinephrine and the norepinephrine. Okay, I just shared that with you. Let me share it. I've shared on the group as well. Okay, so what would be the answer over there? What are the options? So norepinephrine is not mentioned over here. So you will go with the epinephrine. So please correct it. If I mentioned before dopamine, I was wrong. It is epinephrine, okay? So just please correct it. In the urine, epinephrine breaks down into vinyl mandelic acid and metanephrine's, okay? Please correct it. G, these meta-adrenalines and these see, neuroblastoma, metanephrines, yes. So metanephrines are coming from epinephrine. I just show you how these are coming. These are the breakdown products of actually epinephrine. Okay, metanephrines and vinyl mandelic acid. You check both in the case of neuroblastoma. Okay. Now, researchers studying effect the new drug melatonin on the sleep pattern of 100 patients with neurodegenerative. The researcher records the sleep duration and the quality before and after the treatment to determine if there is any significant difference in the sleep pattern. Which statistical test is most appropriate to present the null hypothesis in this study? Okay, so the same population is there and you are checking before and after, okay? So this is most likely you will go with the peer T test. Peer T test. Now, next question, a researcher recruits a group of 250 adolescents from the same region to study the effect of the new drug on a specific health outcome. The participants are randomly assigned to receive either a new drug or placebo. Neither the participant nor the researcher knows. So it's a double-blinded placebo randomized control trial. So the answer would be A over here. Okay. Next question, a child presented with recurrent syncopal attacks. Cardiac catheterization reveals the test. So if you just start with the saturation of the femoral artery is telling me this is a acyanotic heart disease. Now, if I look at the saturation first, SVC, right atrium, right ventricle, all are okay. Pulmonary artery, all are okay. Left ventricle saturation is also okay. But if I look at the pressures, I see that over here, right atrium, right ventricle, pulmonary artery, that is all okay. But when I look at the difference between left ventricle and femoral artery, there is a difference of 50 millimeter of Hg. Probably stenosis is there. What I'm suspecting, probably the aortic stenosis, or I'm suspecting coarctation of aorta, something like that. So the answer would be aortic stenosis. Okay. 8-week-old baby presented with recurrent baby vomitings and the ABGs are in front of us. What does ABGs shows that? It is a show alkalosis, metabolic alkalosis with hyponatremia, hypokalemia, and which of the following is the most likely cause of low potassium in this baby? So why low potassium in this baby? Which of the, so this is the case of the basically the pyloric stenosis, okay? And in the vomiting, you are losing your hydrogen chloride, okay? Your HCl is losing. So why you have a low potassium? Potassium loss from the vomiting, hydrogen from loss from the vomiting, loss of chloride from colon, a defect in the loop of Henle, renal tubular acidosis. So over here, the potassium levels is low. Why? Because you are not losing the potassium, you are losing the hydrogen And because you are losing the hydrogen, no, loop of Henle is okay. Why there is a defect? This is a present with the vomiting, na? So this is not presented with the polyuria. This is a baby diagnosed with the pyloric stenosis. Yes, pyloric stenosis is there. No, why RTA? No RTA, why? There is no polyuria. Just look at, focused on the complaint. This is very important. Recurrent vomitings. There is no history of polyuria. So if no polyuria, you would not think about RTA. You would not think about defect in the loop of Henle. Everything same. No, these are not the answer. There is no diarrhea, no colon problem. You have to decide between these two. Okay. Over here would be potassium loss from the vomiting, hydrogen loss from the vomitings. So what happens if you lose the hydrogen from the vomitings? You have alkalotic picture, okay? But they are asking what is the cause of low potassium level in this baby. We know hydrogen we are losing. Can we lose potassium in our vomitings? If you have alkalotic picture, what you will going to do, you will try to absorb uh, hydrogen. When you try to absorb hydrogen, hydrogen and potassium go along with their sides. They don't go, I think, in opposite direction. Just a second. In pyloric stenosis. In pyloric stenosis. Due to the loss of hydrogen and chloride ions. So they are saying that infant with severe vomiting caused by pyloric stenosis can develop profound hypochloremia and hypokalemia. And this classical picture, okay, so say prolonged vomiting cause loss of HCl, produce increase of bicarbonate in the plasma to compensate for the lost chloride and sodium. The result is hypokalemic, hypochloremic, metabolic alkalosis. What is the mechanism of hypokalemia in the intestinal obstruction? Potassium losses are not seen in the initial days due to the immense store of intracellular potassium. Excessive urinary loss of potassium without normal dietary intake is more important than loss into gut lumen as a cause of hypokalemia in the intestinal obstruction. Potassium level become low because too much is lost from the digestive tract. Chloride is not mainly direct loss of potassium. It's not the direct loss of potassium, but that of chloride causing high level of aldosterone, which inhibits the potassium reabsorption from the kidney tubule. So this is the answer. This is actually the answer. Why you have, because your HCl is losing. That is why that leads to the high level of aldosterone, which inhibits the potassium reabsorption. This is the answer. So yes, you are absolutely right. Over here, the answer would be yes, HCl loss. Hydrogen HCl loss from the vomiting. That is the one reason for the you are not losing potassium directly into the vomiting. So the answer is B, yes. Which of the, because of the increased level of aldosterone. Aldosterone, okay. Which of the following artery is a part of the circle of Willis? So circle is anterior cerebral artery. 3-month-old infant presented with poor feeding, pale appearance. The baby was initially breastfed, switched to formula 1 month ago. The notice. Okay, the mother now reports that the baby has loose stools. Infant's growth and development are normal. CBC show as following. 3 months PHB is 10. MCV is okay. MCH is okay. Platelets is okay. So I think this is anemia of the prematurity. What is the likely cause over here? Physiological anemia. MCV is okay. So it's physiological anemia. Which of the following hepatitis DNA? So it's hepatitis B is a DNA virus, which can cause unconjugated hyperobilemia in the neonate. It is because of the we have discussed already the beta glucuronidase activity increases intrahepatic circulation. Increased UDP activity will not cause hyperbilirubinemia. It will be decreased UDP glucuronide transferase activity. Okay. So the answer over here is beta glucuronidase activity increases intrahepatic circulation. That is reason for unconjugated hyperbilirubinemia. Okay. The more enterohepatic circulation would be there, the more jaundice will be there. Okay. Which of the following drug is most likely with the Steven-Johnson syndrome? So carbamazepine is more associated with the Steven-Johnson syndrome. 15-year-old girl with anorexia nervosa and phosphate levels are low. So they're asking about, because they are started on the NG tube refeeding, why phosphate level? Because of the high levels of the insulin. So it is basically intracellular shifting of the phosphate due to the increased insulin secretion. Now, father 59, mother 23, they have a Downs baby. What is a common cause? Maternal non-disjunction. What is the most likely cause of transposition of great artery during embryonic development? So transposition of the great artery is basically associated with the, this is failure of the aortic pulmonary septum to spiral. Spiral issues is there, okay? A case of TAPVR. TAPVR, what does it show? It shows obstruction of the pulmonary veins. Now, term baby is diagnosed with the hypoglycemia, glucose infusion rate 8. Still, she is hypoglycemic. What is the most likely cause? Increased production of the insulin. Okay, that is why despite 8, it's not maintaining. Okay, so this is increased production of insulin. 7-year-old presented with a seizure secondary to hypoglycemia. Blood sugar is 2.1. Mother reports grandfather glucometer reading of 4.3. Grandfather glucometer reading. Investigation revealed high insulin level, decreased C-peptide. High insulin, decreased C-peptide means the child was taking exogenous insulin. If you form inside the body, the C-peptide level should also be raised with the insulin levels. In 78, how can it show pulmonary venous obstruction? How can it show pulmonary venous obstruction? In the TAPVR, snowman appearance will be there. And that snowman appearance, the cardiomegaly is due to the overload of pulmonary, the blood circulation in your right side. So the pulmonaries you have, no, it's not pleural effusion, it's not poor venous drainage. Pulmonary veins obstruction occur, yes, because sometimes in infracardiac or supracardiac, especially the infracardiac, is associated with obstruction as well. So the TAPVR basically telling you that the drainage, all the blood is draining into the right side, So right side become too congested, cardiomegaly, and sometimes obstruction can also occur, especially in the inferior TAPVR. Okay, so that can be shown by the X-ray. Now, a rate of growth higher among the individual 14 compared to the 18. Why? Because of the behavior and poor impulsive behavior and poor risk assessment skills. Why is the rate of RTA higher among individual age 14 to 18 rather than 20? Impulsive behaviors. A girl 16-year-old with pubic hair and normal genitalia, bone age is 6 to 7, adult order, weight is on 90th centile, and pubic hair, only pubic hair with normal genitalia, bone age is okay, weight is higher, height is higher, so most likely this is pubarchy, premature adenarchy. Epstein anomaly is caused by lithium. Okay, just a second, I'm coming. Okay, come to the back to the question number 85. 84, sorry. Operated chylothorax, you will give MCT diet, okay? That will directly goes into the portal venous circulation. Now, 6 month, what they are asking, 16-month-old present with bruises. Physician is concerned about NAI. Bruises are located in the areas less commonly associated with the accidental. Which of the following side is most frequently associated with an non-accidental injury in this age group? So they are asking about the 16-month. The trunk is the site which is associated less in case of the non-accidental injury. Infants came with the poor feeding, with the vesicles on foot, hand, and lip, and ulcer. So, what is the causative organism? Coxsackie virus is associated with hand, foot, mouth disease. The ulcers are on this specific area. So, most likely this is Coxsackie virus. Marfan syndrome case, long baby, in which mother and sons both have the disease but different symptoms. Son has the mutation but normal phenotype. So what does it explain? It explain if you have a mutation and the phenotype is okay, that means the expression is variable. So it is variable expression. Some are expressing different way, others are expressing different way. They have mutation, but the way of expression of that mutation is variable. Okay. Patient with the celiac undergoes biopsy, crypt hyperplasia, and villus atrophy. Which type of immune cell are most closely associated with this pathological finding? So it is most associated with, T cell mediated. The T cell mediated damage occur to the intestine. Next, this is a 6-month girl presented with episodes of drawing legs, excessive crying, previously documented systolic murmur heard on the left upper sternal border. Mother reports she had 3 similar episodes based on these symptoms. What is the most likely diagnosis? It's a tetralogy of the palate. Cyanotic heart disease, 6 months, she is presenting with spells. Newborn baby diagnosis with posterior urethral valve on antenatal scan. After birth, the following complication should be closely monitored for. So this is posterior urethral valve. You have to be monitored for the lungs. Okay, pulmonary hypoplasia. Anything which causes oliguria is associated with hypoplasia. Okay. Next case, this is a child visited to the camp, developed watery diarrhea. What is the most likely? So camping visit and then develop profuse watery diarrhea. It is most likely related to the cholera, and in the cholera it is activation of the chloride channels in the intestine. Child developed respiratory distress in 12 hours of life, not tolerating feed, gas in the abdomen. So what do you think? If it is gas in the abdomen, this is means with the fistula. So with the fistula means that proximal atresia and distal trachea with esophageal fistula. A newborn Newborn presented with ambiguous genitalia, no palpable gonads. Karyotype is 46XX. What is the most likely cause? Most likely cause would be in this case excess androgen from the adrenal gland. Okay, probably the fetal adrenal glands. Fetal adrenal glands. Question from recall related to an NT in 1000, 2 in 1000. So what would be the absolute elimination risk is? So we all know that NNT is equals to NNT in 1000, 2 in 1000. Okay. So NNT is, what is the formula for 1 NNT is equals to 1 divided by absolute risk reduction. Okay. Absolute risk reduction. Total population. Sorry, because of the network connection, I was unable to connect. Okay, so I was talking about the NNT, okay? In the last, we were on the last NNT. How to calculate the NNT. So basically, I was right. The formula for the NNT was 1 divided by absolute risk reduction. This is equals to NNT, okay? They have mentioned the NNT, that a question from the recall, that in 1000, 2 in 1000, okay? Answer absolute elimination risk is, so if your number is 2 in NNT, just put the 2 over here. 1 divided by absolute risk reduction equals to 2, okay? And when just 1 divided by 2 and put the absolute risk reduction on the other side, what would be the answer? The answer would be, this is 1 divided by 2 is equals to 0.5. It would be 0.5. They are saying 0.05. 2 in 1000. NNT in 1000 people. So N is the number of the people. 1000 people may only 2 would have 1000 divided by 2. Just a second. 1000 calculation. Okay, just I'll tell about that question later on. Sorry. Document, that's a task. Okay. I'll tell about that question later on. I cannot explain that question right now about the absolute risk reduction. I'll tell you soon, okay? So just hold this question for now. We have a network problem. I think you can't hear me. Can you hear me?